I want to welcome all of you and thank you so much for joining us. My name is Stephanie Paul, and I am the Executive Director for MyFace, and I'm pleased to welcome you to our program today. This web education program is designed for families of children with craniofacial differences, caregivers, and healthcare providers. I would like to thank the Milbank Foundation for funding this important program and acknowledge their appreciation for the critical need to provide educational programs like this one for families of children impacted by craniofacial differences. MyFace has a long history of providing access to comprehensive medical and dental care, along with education and direct patient services, paving the way for better outcomes. At the heart of our approach are three pillars of support. First, through our grant funding, we fund top-level organizations across the nation delivering quality, comprehensive craniofacial care to ensure that patients receive surgical, dental, psychosocial, speech, nutritional, and other aspects of care in a coordinated fashion. Second, through our range of direct services, MyFace aims to meet the day-to-day needs of the craniofacial community by offering support groups for affected children and adults and parents, distribution of newborn care kits specially designed for babies born with a craniofacial difference, and housing for families traveling to New York for treatment. Finally, we strive to educate patients, families, and healthcare providers through programs like this Transforming Lives webinar series, and we raise public awareness about craniofacial differences through the Wonder Project school assemblies and our monthly podcast, My Face, My Story, Voices from the Craniofacial Community, where individuals can share stories, be seen, and be heard. MyFace is here to bring together the craniofacial community and help transform the lives of children and adults living with facial differences. We believe that everyone deserves the chance to thrive and live the best life possible. And now on to our program. We have two presenters today. Our first presenter is Dr. Mark Urata, Division Chief of Plastic and Maxillofacial Surgery at Children's Hospital, Los Angeles, Audrey Skirble, Kenneth Endowed Chair and Chief of Plastic and Reconstructive Surgery at Keck School of Medicine at the University of Southern California, and the Associate Dean of Surgery and Hospital Affairs and Oral and Maxillofacial Surgery at Ostrow School of Dentistry of USC Los Angeles. Our second presenter is Alessia Johns, pediatric psychologist at Children's Hospital Los Angeles, Associate Professor of Clinical Pediatrics at Keck School of Medicine of University Southern California in Los Angeles. We will also hear from our family speakers, Samantha and Jake Reese. After the presentation, we will open the program for questions from participants. As you think of questions for our speakers, please enter those questions in the chat on your screen during the program. It is now my pleasure to turn the presentation over to Dr. Mark Urata.
Thank you, Stephanie. It's a pleasure to be here, and I'm so honored and appreciative that an organization like MyFace exists for the benefit, obviously, of many of the kids and the families that we treat. I'm going to talk about syndromic craniosynostosis this evening, and I'm going to kind of breeze along this, and I just want mostly for all of us to understand concepts and to make sure that we leave time at the end to talk a little bit more about if we have questions that we want to answer. So syndromic craniosynostosis is when you have a premature fusion of the sutures of the skull at birth. Those usually happen when the babies are in utero, and they're associated with other birth defects or anomalies in well-defined patterns. And some of these very more commonly are bicoronal synostosis, which, as you can see, are associated with Cruzon syndrome, Apert syndrome, Pfeiffer syndrome, Sayre-Choutzen syndrome, and Muncke syndrome, and there's a host of other ones that I didn't even mention here. And on the side of those, you can see that those are associated with a lot of genetic abnormalities in the FGFR2 and the twist gene when it comes to Sayth-Ray-Choates and FGFR3 and the Monkey syndrome. So there is a genetic component of this that obviously plays a role in why more parts of the body other than just simply the skull are affected. As we look at the skull, this is normally what the skull looks like from above. These are the normal gaps or sutures that babies are born with. The reason why we have those gaps is the brain goes so rapidly after birth that the only way for the bone and the skull to accommodate for that growth at that speed is for us to have these gaps. And that if we were dependent on bone stretching, it wouldn't occur adequately. So when one of these gaps closes prematurely, then the brain comes under some pressure, and also it obviously causes a deformity of the skull. So most commonly in syndromic bicoronal synostosis, which are the two coronal sutures you can see in this diagram, one on the right and one on the left, both of those sutures typically close prematurely. And if that happens, the patients get a wide skull. Their skull ends up being tall, which we call turicephalic. And these other terms below, basically, I'm going to show you as we look at some examples of that. And here's an example. The eyes or palpebral fissures, meaning the opening of the eyes, can be wider than typical. And as you can see, they're a little almond shaped. And in this particular case, they're not fairly symmetric. The midface of this child is a little deficient. It's a little bit flatter than some kids that don't have a syndrome. And so those are two of the things that we look at here. And then if you look at the patient from a side view, again, you can see the midface is not projected because it looks like the eye is sticking out. The nasal bridge is flat, which is pretty typical. And the forehead is more posteriorly or further back toward the ear because the sutures have frozen, so it's not allowing the brain to push the forehead forward. So we basically operate on these kids for two reasons. One is we want to make sure that there's enough room for the brain to grow. And the second is we want to achieve a natural appearance of the skull. I think I stay a little bit away from normal because there's a wide variant of what we consider normal. And naturalization to me means, does a child look more like the father and the mother? I think of these, when it comes to syndromic synostosis, as a marathon and not a sprint. A sprint would be this non-syndromic synostosis where we just are repairing one suture. We do one operation, and most of the time, that's all we need to do. But for those with syndromes, it's a 20-year work of what I consider art and nature. And we focus on the foundation, anticipating that the surgical needs of the future while visualizing the end result. So what do I mean by that? This is the artist's concept of what the Golden Gate Bridge might look like before it was anything in existence. And I'm sure when they took it into account, they thought, well, what is it going to look like with the backdrop of the city or the backdrop of South Salito on the other side? What's it going to look like with the cars, and how is it going to function? And as they started to put the pilings in, you would not be able to visualize that in your mind's eye necessarily, but the creator and designer of the bridge did, in fact. But that person was more focused in on the strength of what they were building and making sure that the foundation, this is where they separated out the bay from putting in these pilings. And they basically poured these so that this would have a strong foundation, knowing what they were going to build on top of it. And this is how they built that up from the bottom of the bay. And this, of course, is what we all appreciate to be the Golden Gate Bridge now today, both a functional beauty as well as a natural beauty. And that's the same thing that we're doing with these kids, is we know what we want these things to look like and function down the line, but we have to take each step, and each step is built upon the step prior. So here's a child with syndromic craniosynostosis. This child happens to have Apert syndrome. You can kind of tell in the picture because the mitten hands where the fingers are not separated. And this is the child at the end. And so that's an example of visualizing what this particular child, now a young adult, almost finished with college, potentially should look like downstream. She has since had braces, her teeth are all straightened, and she's doing really well, as I said, in college. Now, there are a number of different techniques, and I'm not here to talk about what I think is best, or because I think there's a number of outstanding surgeons all who use different techniques. But the point of all of this list of techniques is just to tell you that in the landscape of taking care of these kids, we have to take all of those techniques into account in addition to relapse, complications, psychosocial implications of doing surgery at specific times, the risks of anesthesia. Are they skeletally mature and done growing? Are their teeth erupting? All of those things factor in to when and what we are going to do. I will say that what we have done at Children's Hospital Los Angeles and USC is develop not just a craniofacial team, which is really important, but also craniosynostosis team that specializes in taking care of these kids with an ophthalmologist and obviously a psychologist with Dr. Johns on this webinar, and then a geneticist. So many people that are important when you're taking care of these kids. And then when they come to me, we get CT scans. And we look for a number of things, including, do we see signs of pressure on the brain at the bottom in the back, which is called a Chiari malformation. And as you can see here, if you have multiple sutures in a Kleeblatt Schladel, a German term for clover leaf, that those patients often have pressure in that area, and that needs to be addressed. And then the other things that we do is we take a 3D picture of the patients, and then we prepare them to make sure they understand that they need to give blood. Now, this is my own personal craniofacial roadmap, and I'm in no way going to go through explaining every part of this, but just understand that when I set out to develop a map of how I take care of kids that are syndromic with craniosynostosis, I wanted something easy. So I wanted, in Los Angeles, we have so many freeways and roads. We really want the easiest way to get someplace, but more often than not, we're going down back streets and different turns. And the same thing is true with craniosynostosis in the face of syndromes. It's not easy and it's complex. And so let me just take you through a little part of this map so I think you can learn. And we're going to focus in on the top part of this, which is in fact just addressing the craniosynostosis. So when these kids come to me, I have to decide, do they have severe brachycephaly? Do they have severe pterocephaly? Remember, brachycephaly is a wide skull, pterocephaly is a tall skull, or the Chiari malformation mentioned, which is the pressure on the back of the head where the brain is near, where brain enters from the spinal column. And if the answer is yes, they have a severe amount of that, then I'm actually going to expand the back of the skull first with the posterior distraction. But if on the other hand, the kids don't have it, then I'm going to straight to advancing the forehead. And let me just show you briefly a couple of quick examples. So this is the child that I showed you before, Apert syndrome, came to us. The skull overall had pretty good shape. And because of that, all I did was to go straight to a frontal orbital advancement in calvarial vault remodeling. I didn't do posterior distraction. I moved the forehead forward to give the child an overall nice contour. And you can see the forehead's moved forward, the contour's improved, and the brain has room to grow. On the other hand, in those kids that are really tall and really wide, as in this child, and then I do, in fact, do posterior distraction. So you can see here that this child has a distractor in place. There's a tiny little metal you might be able to see there above the ears, and you can see that there's a scar. And what I'm doing is I'm stretching the back of the head slowly back to create room for the brain, because that's going to allow me to lower the height so that I'm not putting pressure on the brain. And so I do those distractors, and I expand the back of the head over a 2-week period, and then I wait for 2 or 3 months. Then I come back and do what I did on the first child, which is to go ahead and expand the forehead. So here's an example of that. I move the skull in the back first, and then I come back and I do the front where I move the forehead forward. And this is what I'm doing. This is all diagrammatic with the red here showing I'm going to move the forehead forward, and that's going to allow me to lower the skull because I've already moved the back of the skull backwards. These kids stay overnight in the ICU, usually a night. They stay a couple of nights to 3 nights on the floor, and then they go home. And that may seem crazy to a lot of parents because it seems like a big operation and they're going home. But we've done this so many times that we know how to do it safely, and the kids are well taken care of, so they're safe to go home. And they certainly don't get discharged if for some reason, in some specific instance, we think that they should stay. So let's go back and look at the skull. So you can see, although the hair is bird nested, you can see that this child now has a forehead that's forward and the back of the skull. So preoperatively and then postoperatively, we moved the forehead forward and gave an overall more natural appearance to the skull. And the follow-up appointments for the synostosis part of this, The PS is for the plastic surgeon. The NS is for the neurosurgeon. And you can see here that I see the child 1 week after discharge, 2 week, 1 month, 3 months, 6 months, and then 1 year, and then every year. And just to really breeze through, these are some plastic model skulls, actually by a gentleman, Jeff Marsh, out of Washington, St. Louis. But you can tell a normal skull on the left and Crouzon syndrome on the right. And I'm just going to show you these. You can appreciate, excuse me, how tall the head is and how wide. And then in Apert syndrome, the same thing, tall and wide. And the midface is a little bit flatter on an Apert syndrome. And then the same thing with Pfeiffer syndrome. You can see looking here, the skull's a little bit more elongated here, but all three of these have in common that those coronal sutures are together. So here's an example again of another child with Apert syndrome. You can see the mitten hands in the bottom of the picture. And we go down this algorithm of taking care of the craniosynostosis first. And once we've advanced her forehead forward, over time, we monitor her and she comes back to us. She's now about 7 or 8 years old. And you can see that her midface has not grown much at all. So her forehead is forward. And again, like the Golden Gate Bridge, the forehead is forward. So that would be equivalent to putting in the foundation of the bridge. But now we look at her, and now we need to put the other parts of the bridge together, which is to move the midface forward. And so here she's a cute girl, but she has a remarkable underbite because her midface is deficient. She get a little bit older, and now she's at the age where we believe we can operate on her. And so what we do is we look at her CT scans, and we're down in this part of the algorithm where you can see midface hypoplasia. That simply means that the middle of her face is not growing forward. So I'm going to do a Lefort 3 distraction. And that means I put a device in my hands. I put a device underneath the skin. I make some cuts on the skull, and I slowly move the midface forward. And this is her after the devices are removed. She happens to live in my town and is the daughter of family friends. So I get to see her all the time. She's actually much older now than this and is doing fantastic. Her teeth have been straightened out by braces, which we're doing at this point. But now this is a child that goes to school and is doing really well and is integrated. And her teeth, like I said, are starting to come together with braces. Sometimes we have to do a larger surgery where I have to actually get on top of the brain, protect the brain, and actually separate the face and move the eyes together because the eyes are further apart. So this is another child, and I showed you her when she was young. She underwent the frontal orbital advancement and the calvario vault remodeling for her bicoronal synostosis. But then as she got older, I had to then, like I said, bring her eyes closer together because they were further apart here, and then stretch the entirety of her face forward with a monofacial bipartition, which is the diagram I just showed you. So here she is. You can see her left eye is lower than her right eye. She has an underbite, but a super sweet kid. And we put a device on that I designed. You can see a silhouette of that device underneath her skin. And we push her whole face forward after I've already moved her eyes close together. And this is her now. We have some other pictures now. She's, in college, like I said, her teeth are all lined up, but this shows you her eyes are at the same level. And for a kid who had Apert syndrome, you could argue that, 5 feet away down the street, she's just another kid, which is exactly what we want to happen. And then finally, at the very bottom, the gray area here is when the kids are done growing. That's when we can kind of finish off this whole work that we've been working on. Here's a young woman who had her forehead move forward and for her bicoronal synostosis, but her midface was further back. And so ultimately I ended up moving her upper jaw forward and the lower jaw back. And so her teeth, she had an underbite before we did the surgery. This is her afterwards. And then looking at her from the front, and her teeth are all lined up. I think I have a picture of her teeth now fitting nicely together. She's now done with college. Actually, I think is married and doing really well, but that's a perfect example, again, of having eyes on the long run. So if we revisit the Golden Gate Bridge, it's just another reminder that our masterpieces in my hands are not, in fact, bridges, but the kids that I take care of, like Jake, who you're going to hear from, with a remarkable family, just unbelievable family. And so these are our true masterpieces that over time we get to this point where we achieve, our equivalent to the Golden Gate Bridge. And so with that, I want to introduce my partner, Dr. Alessia Johns. Alessia, take it away.
Thanks so much. And I have no disclosures. This is a great opportunity to talk about how this all comes together in neurodevelopment, which is something that families are always really interested in hearing about, and our team cares about as much as the surgeries, I think. So what do we mean when we talk about it? It's something that refers broadly to a lot of different things, but it links back to cognitive or intellectual functioning overall, which we sometimes call intelligence quotient, or IQ, and that's sort of the acronym I'll be using throughout the talk. And I wanted to say that there's so many other areas that are really important to know how kids are doing academically, adaptively, psychosocially, but those are generally thought of as different from cognitive development. However, one global area that I will touch on a little bit is health-related quality of life, because that also gives you sort of a global idea of how things are going all together. So assessment is something that varies a little bit over time. When we're looking at early development, which is usually birth to about 3.5 up to age 5 or 7 on some tests, we're looking at cognitive functioning, language, and motor skills. And then starting in childhood up through adulthood, it's focused more on all sorts of different areas of cognitive functioning, which includes visual processing and language and working memory. And all of these standardized tests have gone through very rigorous process in order to be developed to make sure that they're both reliable and valid. But the raw scores on their own don't actually have any meaning. They only have meaning when they're compared to the norm sample, and they fit within a normal curve. So a standard score will have a mean of 100, and then about 68% will be above and below the mean of 100, which is a standard deviation of 15. So before we talk about some of the results, I wanted to just give a context that in addition to everything that's going on medically, we know that there are so many different environmental factors that impact development. So there are prenatal risk factors, premature birth, family socioeconomic status, which refers to parental education, income, occupation, certainly nutrition, environmental toxins, traumatic stress, developmental stimulation that's in the environment, and also the caregiver relationship. So this impacts development for all children. And then on top of that, we have the specific things that happen for kids who have syndromic cynostosis, which can impact vision and hearing, syndactyly, or the fusure of the fingers or toes, as we heard earlier. There can be difficulties with breathing while awake and while asleep, cleft palate. There are lots of different genetic variations. There can be hydrocephalus, as well as structural brain differences. And one area that you heard Dr. Urata talk about in particular that we think about most often is the possibility of increased intracranial pressure. So I'm going to go through a couple studies that look at this specifically. This is a study that came out of Philadelphia, and it had 19 children out of a group of 45 with synostosis that had syndromic cynostosis, and 68% did have elevated intracranial pressure, and that was through direct measurement with a probe. But only 4% had a marker on eye exams known as papilledema for intracranial pressure. So it looks like it's probably happening more often than we see in our screening measures. But wonderfully, the decrease, as we would hope after surgery, did happen for 96% in the sample. And there was no difference based on the type of surgery. They did see a trend that younger children were less likely to have elevated intracranial pressure. Some other examples out of London, you can see this is with a group of kids with Apert syndrome and another with Cruzon syndrome. And they did have the same benefit of surgery of intracranial pressure going down. But I think what's really important in following them longitudinally was seeing that there were recurrences for a substantial proportion. And I think this really highlights this idea of what Dr. Urata was referring to. It's not a single surgery that is a cure per se, that it is going to be a series of multidisciplinary treatment and ongoing monitoring to make sure that we're catching things like a recurrence of intracranial pressure if it pops up. And before we talk about what we do know, I think it's also important to just really highlight how much our knowledge is limited. Part of that is based on the reality that these are very rare diagnoses, and so we just don't have the ability to get large groups of people together to see how they're doing, and studies have pretty small groups for us to look at. Another limitation is that the measures that we use are very different over time and over different centers and countries, so it's hard to put that information together meaningfully. And as I mentioned, there's so many different contextual factors that also impact development, and they're often not accounted for, unfortunately, in research or in clinical care necessarily. And we're learning more and more about the genetic variations. However, we don't necessarily always have that information in the studies we're doing, and also it changes very rapidly. So some examples of recent advances that are being done with animal models, which are usually with zebrafish or mice. There was a group looking at a Cruzon syndrome model that they were able to see what was going on with the part of the brain known as the hippocampus and help address some memory impairment. And then in a Say-3-Choatsen model with a group that Dr. Urata works with, they also were able to look at intracranial pressure and address that as well. So we're unfortunately a long way from this actually impacting how humans are cared for, but I think it's great to look and see that this is happening and know that in the future this will probably impact how care happens for humans as well. So I'm going to start off looking at some of the research we have for syndromic synostosis as a larger group, and then look at some specific syndromes. So this is a Dutch study of 76 individuals. And if you remember, exactly average for IQ is 100. And so 97 overall, the group average was right on track with their peers. However, about a third did have a below average IQ, and about a third also had ADHD. In a more recent, larger Australian study that also included a large group of the general population peers without health issues, 23% had intellectual disability, and that refers to having an IQ of 70 or lower and additional difficulties with being able to independently take care of daily living skills. And that incidence rate was actually almost 16 times higher than the general population sample. They also found that autism spectrum was 4 times more likely than their peers. And one of the things that families are usually interested in thinking about, when can we know if these diagnoses are going to apply to their child? And so in this study, these diagnoses were generally made between the ages of 3 and 4, which reflects when you can accurately and more reliably diagnose intellectual disability. Autism is something that you can actually do a little bit younger, starting around 18 months. But that was sort of the age range where those diagnoses were made recently in this study from Australia. Looking at another study that I mentioned earlier, looking at quality of life, is also sort of a global measure of how things are going. This was with a group of parents and adolescents in the Netherlands, and they definitely were worried. Parents rated lower quality of life for their kids in 80% of areas. And we saw the impact of contextual factors, and that social economic status was lower for those that had higher concerns about psychosocial quality of life. But in contrast, the adolescents themselves thought that they were doing great and didn't have differences from their peers. And in fact, they had some of the opposite results from their parents. And the other thing that was really interesting about this study and very important is that parents were reporting on their own quality of life, and they were also lower for 2/3 of the areas compared to their adult peers, which I think really highlights the needs of families as well. These are studies that have the same pattern of when we ask people to report on their own quality of life. They're doing great. In a group from Brazil, they were in the good high range for 88% of areas, including self-esteem, social support, thinking, learning, concentration. And similarly, in a UK population, they were actually higher than the general population. One of the things that we see across the craniofacial literature is that when medical providers rated the appearance of what they thought was going on, it had no relationship with what people themselves reported about how they were feeling. I think that's probably helpful for families and providers to remember as well. So looking more specifically at some of the syndromes, starting off with Muncke syndrome, we have some Dutch studies finding average IQ for the group overall, with about 40% that had a below average score. Parents were worried about speech, vision, and emotion. And then in a very small study of just 4 individuals in Australia, they also had a distribution across their IQ range, and 75% completed secondary school, and 2 of the kids who were in that study also had special education support. Moving on to Say-3-Choatsen, Again, an exactly average overall group IQ with 21% that were just below average. And parents were worried about vision and speech primarily. In a group of 30 kids in UK and Oxford, they had confirmed that they all had a twist 1 difference, and they had 80% hearing loss, which was presumed to be conductive and so responsive to hearing aids. They did see that, as we saw before, that there was intracranial pressure both before and after surgery. And specifically, when they looked at language delays, they did find that there was a relationship to the type of difference in the twist1 gene, and that if there was an entire gene deletion, there was actually more significant learning issues with language. And they also found that language dropped for those people who had longitudinal scores when their intracranial pressure increased. So those were sort of validating some of the things that we see in clinical care. Moving on to Cruzon syndrome, we have a pair of studies from Brazil that found structural brain differences with 43 and 60% of those populations, with a wider range of those kids who were in the range for intellectual disability of 9 to 37%. Language and academic skills were below average, and in one of the studies, socioeconomic factors also played a role. In a different study out of Australia, there was again 55% of kids who were in the average range, and only 9% that were having intellectual disability of that IQ lower than 70. 91% completed secondary school, and a fifth went on to complete university. Parents in the Netherlands were worried about vision, speech, and cognition. And then looking at Apert syndrome, again, we have a different pair of studies from Brazil that found, again, about half to 60% had structural brain differences identified, that there was about 22 to 37% who had intellectual disability range score. Language and academics were lower. And there was no association with the scores between surgical status, age of surgery, or the structural brain differences that they identified. In this study from Australia, they found that 43% were having some at least scores above 70. They didn't give how high the range went up, and 57% did have intellectual disability of varying ranges. There was language delays for everyone who was in the study, but 18% did go on to achieve typical speech and language skills overall. And there was about a quarter who had special education programs, and everyone else had some assistance in general education. 29% went on to post-secondary training, and a third were employed at the time of the study. There was also some research done that's a little bit older out of the UK looking at Apert syndrome with 48% having intellectual disability. 52% with intellectual disability. The rest were above that cut mark. And they did not find an association between surgical timing or approach in that population either. And all parents were concerned about dexterity, understandably, given the seizure of the syndactyly for the fingers, and fine motor skills. 80% for speech, cognition, as well as vision were some of the concerns for them. And then finally, looking at Pfeiffer syndrome. Pfeiffer syndrome is something that's generally classified into 3 different levels. And this group from New York was trying to find a functional classification system. And they had a lot of great findings. One of them was that, unfortunately, even with the exact same genetic findings, even within the same family, there was a really wide range in severity with identical genetic results. Only 17% fell into what would be called the mild functional range, and 21% were in the moderate range, which had higher rates of ADHD as well as developmental delays. And then the largest group had severe functional impairment with very frequent elevated intracranial pressure, a lot of other significant health issues, and unfortunately also early mortality. One of the things that they also reported on is that across all of these ranges of function, there were some kids who had no craniosynostosis, none of their sutures had closed early, and others who had multiple sutures closed across all of these ranges. So again, there wasn't a one-to-one correspondence between what we would see in function and what they presented with on the medical side. A group in Seattle of very small patients, just 3, they did find that if they altered their surgical protocol, they were able to have better outcomes with average cognitive development, and that included ongoing monitoring for intracranial pressure and intervening when it was present. And then there was a small study from Australia with just 5 kids, and they also found 40% average, 40% in intellectual disability range. They had most complete secondary school, some with the assistance of an aide, and one of the kids went on to complete university. So I just breezed through so much information, but I think there are some general implications that we can take away. The first is just to reiterate how much we're still learning. We just have a lot that we're going to find out over time. But we do know, no matter what, intracranial pressure is a significant developmental risk factor, and it's probably happening more frequently than we understand when we just do screening through eye exams. And it does seem to have an increased incidence after age of 12 months. Beyond that general timing, there's not a clear association of specific surgical decisions that are found, but this may just be because we don't have enough kids in studies to see those patterns. And the other thing is that the management of ICP on its own is not the treatment. It is part of a larger treatment plan, and that surgery in itself isn't a quote unquote cure, that it's going to be many different steps, as we heard, to build the Golden Gate Bridge. So the other thing that I think we can take away from all these studies is that there's just such a wide variation of developmental outcomes, even within the same diagnosis, even with identical genetic findings. And so this really highlights how important it is to have individualized ongoing assessment to figure out what's going on for each person and what is going to be helpful for them. The recommendations that come from assessment can be very helpful to make sure that the right interventions are provided. And also, all kids are part of families that are also going through this whole process with their kids. And so they also have a lot of stress and benefit from having support. There are so many things that families can do. And this is just a partial list, but certainly being strong advocates across settings is very helpful. Being able to make sure that their children are using hearing aids and glasses starting from a very young age, which can be a challenge in infancy. To make sure that you're linked to state and local developmental support programs that are available across the lifespan. With school districts, work with having an individualized education program or IEP, which starts at birth for hearing, otherwise at age 3 and goes up to 22. Be in frequent communication with teachers and interventionalists to coordinate home programs, and make sure that they're part of extracurricular activities. Just find what your child loves and plug them into what they enjoy. To include social opportunities for both general education or general peer groups, as well as peers that might have similar diagnoses. It's very powerful to be with a peer group that has walked in your shoes, and MyFace has several opportunities for families to get together. And also proactively coaching families from a very young age how to respond to curiosity and teasing. What are they going to say? How are they going to explain their medical needs and their diagnosis? And to address concerns very quickly if they do occur. So looking forward, I think it is important to remember that for those individuals that have an intellectual disability in their families, there is significant support available across the lifespan. And again, to remember that when we ask people themselves how they're doing, they are reporting much higher quality of life than we might presume as family members or medical providers. And that we saw reported many adults who went through post-secondary education are employed. As we heard from Dr. Rodden, we know from so many of our own families that they're already having their own kids and having these huge full lives as they would with everybody. And also just medical, surgical, developmental, school, psychosocial supports are always improving. And so we think outcomes will continue to improve as well. So these are some of the references that are in the slides for the studies. And some resources include this sort of guide to craniosynostosis put together by a working group. MyFace has a lot of great videos that you'll see a little bit more about in a moment. There's also the ACPA and some other community organizations that you can find here. And now I would love to introduce Jake and his mother, Samantha.
Hi.
Hello.
Hi.
So would you like to do a quick introduction of yourselves, and then we'll go through a few questions with you?
Sure. My name is Samantha Reese, and this is my son. What's your name?
Jake Reese.
Jake Reese. And Jake also has a twin brother and a little sister, Luke and Olivia, and a dad, Lance. He's not here.
Yes. An important part of the family.
Yes.
So thank you so much for joining us to talk about your experiences. If we could start off with you, Samantha, about what was it like for you and Jake's father when you first learned about Jake's diagnosis?
Well, we actually didn't find out until we were in the delivery room. So it was actually pretty traumatic because we did not know. And we had all the testing done and a million ultrasounds and genetic testing and all kinds of stuff. And we didn't know. So it was hard. That was tough. It was also the Sunday night of Memorial Day weekend, and there were no geneticists. Not even my own doctor was there. So that was hard. It was also a long time ago, and we didn't have a lot of online resources. There was no Facebook. It was just a listserv. So it was, that part was really tough because we didn't have any time to prepare.
Right. Yes. Yeah. It is. Yeah. So much to take in at once while you're.
And we had two. There was also
twins.
Also another one. Yeah.
And was there anything that you would say, obviously having the information and having your own providers, was there anything that you would say, looking back, as advice you would offer in that early period for families?
Yeah, I mean, it's hard, but I would say try not to panic, not to, to really try and talk to the doctors and not, Google things, because that really did not help us at all. In fact, that just caused a lot more anxiety, and that part of it was really hard. We actually immediately, though, were able to meet with Dr. Urata, so that was helpful. Within I think almost 24 hours, he had come to the hospital. We had gotten in touch with him. So I think that, and nowadays there are so many groups. Like, there is a group on Facebook that we are a part of that we get so much information from. And anytime I have a question, I have an answer within 5 minutes. And so that is really very helpful. The social workers in the hospital are helpful if you take their help. And so that was really helpful also. But the one thing I would really say is to try and listen to your doctors and try not to panic, because it's a lot to take in the beginning.
Absolutely. No, excellent point. So speaking of the beginning, you had some initial hand surgeries and then occupational therapy. Can you tell us a little bit about how that went?
We did. So in our minds, our goal was to get Jake's fingers separated by the time he was 1. We really just wanted to see those hands like in his cake when he turned a year old. And we had some trouble actually here. We're in LA, and there was a doctor in the hospital that told us that Jake would not have 5 fingers. And so that pushed us to kind of go outside the box and really do our research. And so we actually had Jake's hand surgeries done at Boston Children's Hospital. Now, again, it was a long time ago and things are different. So I know there are doctors that do this procedure now, but we had Jake's fingers were separated in 2 surgeries. And that, they skin graft from his abdomen and separated. At first, you can see this was the first surgery that you're showing a picture of, what separated it into 4 fingers. And then we had a second surgery that separated the 5th finger. And that is a picture of another surgery that we did that was very helpful. It elongated his thumb on his right hand, and they took a piece of bone from his hip and they used it. So now, Jake, actually, you can hold up your hand. So on his right hand, his thumb is almost as long as his pointer, so he can use it to grasp, because they don't have any knuckles, so they can't their fingers don't bend normally, or they actually don't bend at all. And so that was really actually helpful in him using his right hand. It was a painful surgery, and one of his most painful. Absolutely worth it, but we chose not to do it on his left hand because it was unnecessary. And then, yes, immediately following the surgery, we started occupational therapy. And we did it in the hospital and we did it through the regional center. So we had in-home occupational therapy, and that was so important. Jake actually never used adaptive equipment. And I think it's because from 2 weeks after surgery, when his cast came off, or maybe it was 4 weeks when his cast came off, they started doing occupational therapy with him. And he still does it now. But then it was really important. So we would have some appointments at Children's Hospital, and then we had the in-home services also. And they would work on, I mean, at the time it was like, putting his pacifier in. He was really little. He was under a year old. Holding a bottle, which are things he could not do before he had his finger separated. So that was really helpful and important. And as he got a little bit older, he also worked on some really intense occupational therapy for writing and things like that.
Yeah, no, a huge part of your path that you've been on. And obviously then there's been so many craniosynostosis related surgeries as well. If you could tell us a little bit about that.
Yeah, so his first one was a craniotomy, basically. That's the one where you see the top of his head, and he was only 8 months old. That was and he had that one in between the 2 hand surgeries. So, so we kind of tried to work that out so that we kind of were done after that first year for a while. That surgery was, I think, the hardest one, emotionally for us, because, he was a baby. He was only 8 months old. But it was so amazing to see how fast he recovered. We always say, for Jake, because he's the happiest kid in the world, we would just wait to see that little smile. And the second we saw that smile, we knew that he was healing. But that surgery was tough because there's so much swelling. So they do both surgeries, actually. They stitched his eyes closed so that the eyes don't bulge out. So that's really hard because they wake up, but they can't see and they can't open their eyes. But it immediately did make a huge difference. It was it's a little shocking because they all of a sudden start to look different, which is what they're going for. But, we were used to his face before then, but things, became more symmetrical, and also his sutures were closed and they needed to be open to give his brain room to grow. The second one was called a boxed osteotomy. Jake didn't have to have the Lafort. So he had a boxed osteotomy where Dr. Urata he had the space Dr. Urata talked about that was wide between his 2 eyes. So that was a really big surgery, and they moved his eye sockets closer together and did a little stuff also in his cheek, up in his cheekbones and stuff. And that was a really hard surgery. Jake tends to spend more time in the hospital than they ever think he will need to. They'll say 3 or 4 days, and he'll be there for 2.5 weeks because we have some problems with pain management and stuff for him. And also, his airway is smaller, which, kids with Apert syndrome, that's part of the issue. And so extubating became an issue. And so we had some issues with that. So he was there longer. But there in that picture, you can see we brought his brother and sister in for the first time, and he smiled. And that's when we know things are going our way.
And then just very briefly, if you could touch on some of the other things you just mentioned, airway, pain management. So what are some of the other medical specialties you've been working with?
We work with a lot. We ENT, which is airway, but and also Jake has had 6 sets of ear tubes. He's grown out of that now and he's fine, but he had lots of ear infections when he was little, and that's part of the draining and the airway and all of that stuff. So he had a lot of ear infections, and we were on it early on, and he got ear tubes early on. So luckily Jake doesn't have any hearing loss. We see an ophthalmologist. Jake has had an eye surgery. He had strabismus, and he wears glasses. And it was a successful surgery, so that is great because he had no depth perception then. He's had lots of sleep studies to make sure about the sleep apnea. He sees an orthopedic doctor because there's some issues with the feet. We didn't separate Jake's toes. We did have a surgery, and this was so helpful. During one of his hand surgeries, the doctor who did his hand surgery separated all of his toenails because they were one long toenail and they grew over each other. And that was life-changing because he would get lots of little infections. So that some people do separate the toes. We didn't, but that toenail surgery was very helpful. And that's kind of it. Do you see any other doctors that I didn't? I mean, he's his pediatrician. But Jake, like when he gets a cold because of the airway, we always sort of need to do some like steroid breathing treatments. He has a cold right now. And so that's kind of important to know also. We learned that early on, and that we just know we have one at home, and that's helpful. But I think that's kind of it with the providers that we see. One thing we do look for, Jake gets headaches, and when he gets a headache, we know what's going to happen. We're not sure if it's migraines or has to do with some of the surgeries or the way his brain grows, but he does get headaches that sort of turn into migraines, and he will throw up and then be fine or sleep it off. But we look for that. Like when I feel like he's acting a little certain way, now I kind of know what to look for.
Keep ahead of it. So Jake, from your perspective, what do you have to say about some of the surgeries you've been through, and any advice you would give to other kids who are going to have those surgeries?
Just don't be scared. It's going to be easy. I'm normally scared, but it's like when you get put to sleep, it's like you're just sleeping, like you go to bed at night. So it's just like that. Yeah, like I also like to know in advance like what's gonna happen during while I'm asleep.
Yeah, Jake likes to have all the details, and I think as he's gotten older, that really helps to kind of tell him exactly. We've come up also with some, like last time we knew that he would be sleeping for a long time.
Yeah.
So, and that he wouldn't be able to see and he wouldn't be able to talk. But if he woke up and he needed something, I was like, kick your foot 3 times. We had a system, and it actually worked. Yeah. So that was helpful.
Definitely. Yes. Having a way to communicate, crucial. Very good advice. So moving on to school, can you tell us a little bit about what services have been helpful, or what you have found helpful at school?
Having teachers, OT, speech people, knowing that I'll be okay at school.
Yeah, Jake has had aides. We've been able to have, up until now, he had like a full-time aide, which he didn't really necessarily need for some of his classes, but it was more like, because of the hands, he would have a hard time, if there were round doorknobs, if there were, opening lockers and stuff like that. And so he always was felt comfort in knowing they were there. Now he's in high school, and he doesn't have one-on-one aides anymore, and he's actually doing great. But we always had an IEP, and we've always been able to have lots of services in school, and that is very helpful. That's really helpful.
Excellent. Yes, getting to know the IEP team is crucial. And so now, can you tell us a little bit about some of the fun activities you've been enjoying together, and any adjustments that you thought might be helpful for people to know about?
What are your favorite activities?
Probably going on bike rides, skiing, swimming,
traveling. We travel a lot, and Jake's been to a lot of places around the world.
Yeah.
Pickleball.
Yeah, tennis. Art. Yeah.
Musical theater as well. You've dabbled in musicals.
Yeah. Oh, that was the best. Jake did do a lot of musical theater. I wish he would do it again. He was good at it. We loved it. But he doesn't really let anything stop him. I mean, he skis, and swimming was really great early on. Swimming was great because it was something that didn't require him to bend his fingers, and his feet actually helped having webbed feet. So swimming was a big one early on. But I mean, even I'm always more nervous than Jake is. He's like ready for anything. But even I was afraid he wasn't going to be able to ride a bike. And he did it before his brother, which made his brother really mad. But he doesn't really let anything stop him. He just went zip lining. And I was so nervous because he couldn't hold on and that was going to be a problem. And he loved it. And I just closed my eyes, but he was great.
My goodness. Well, thank you so much for sharing those experiences with us. And I mean, just look at, again, another wonderful family photo of you guys traveling and having an amazing time together. And so I think we'll switch over now to some question and answers from the people who are participating with us.
Thank you, Dr. Johns. Oh my gosh. Thank you, everybody, for this incredible presentation. And Samantha and Jake, wow. Jake, you are my hero officially. So let's take some questions. Please go ahead and put your questions into the chat on Facebook and YouTube if you have anything to ask. Please try to make the questions general, and we'll answer the questions in the most general nature possible. So let's start with a question from Kara. And this is for you, Dr. Urata. Kara's daughter has sagittal craniosynostosis. It's non-syndromic, and she's about to have surgery in May. She's 9 months old. They're concerned about what to expect post-op. That's one question. And then also, it's an open surgery, so they're wondering if they'll be able to provide blood themselves for her transfusion. And just a note, Samantha, if you can tell us the name of that Facebook group, that would be super helpful.
Okay, let me look at. Let me find it.
Okay, so Dr. Urata, can you answer that question for us?
Yes, of course, I'd be happy to answer that question. So in a non-syndromic sagittal synostosis that Kara had submitted the question, and it's going to be done in an open approach, which means an incision from the top of one ear to the other. I have a tendency to make a zigzag incision because the hair on the sides of our head grows down. So the more horizontal your scar, the more it's concealed by the hair that travels downward. Endoscopic or minimally invasive is the other way to do these cases. And different surgeons have different perspectives on all of that. I do offer that for sagittal synostosis if they're young enough, meaning if they come to me, less than 2 months old, and then we can do it in a timely manner. And if I feel like the shape is going to be amenable to it. I don't offer that to kids who have and parents who have metopic, bicoronal, or coronal synostosis or lambdoidal because I don't believe it's effective in the treatment of those. But that's my own personal perspective. But to get to her question specifically, which is what do we expect post-op? Generally, if you're having an open approach, the short answer is yes. I do ask the parents to donate blood. At least one parent is typically a match. And then if not, we use banked blood. There is some risk to that, although it's super small. And in the course of my 30 years, I haven't had any outside of what we call a minor transfusion reaction where the kids get an elevated temperature transiently. That's about it. But I haven't had anything major transferred, as an example, within the blood transfusions because the process of filtering blood nowadays is so sophisticated. But we do ask that they donate blood if it's possible. Now, just so the parents understand, once you start to get 2 or 3 generations away from the parents, it's actually not that helpful. So that if you're asking your brother's cousin to donate blood, it's not as helpful to do that. And then in terms of what to expect post-operatively, you're probably going to be in the hospital 2 or 3 nights. Some places you'll go to the ICU for a night and then you'll spend a couple of nights on the floor. And as Samantha and Jake said, it's more about pain control and managing, the experience. But I will say one of the things that Samantha brought up, which is really good, is the personalization of the experience. If you've been doing this long enough, you come to understand that each child is different and the parents often know best. So I think if you're a younger doctor, you might be a little bit more resistant to listening to the parents. But I think that's a really important thing you need to do is listen to the parents. Just as I know my own kids better than anybody else, there's no reason why the parents of these kids shouldn't feel the same way.
Great. Thanks, Dr. Urata. A question just came in. I'm going to put to Dr. Johns from Ryan. Are there specific neurodevelopmental or psychological tests you recommend children with syndromes undergo to help identify helpful resources?
Yeah, so once they've gotten to childhood age or out of early childhood and in school, then it's important to have a basic understanding of how things are going overall with their cognitive functioning. So going back to that IQ, so a general cognitive measure, the Wechsler, are one of the most widely used, but there are other measures that are out there. And then in addition to that, you should have an academic measure, such as the Wyatt or the Woodcock-Johnson. And then there should also be tests of attention, of language, of processing, both, and then auditory and visual memory, as well as looking at what's going on psychosocially to make sure that there's not something happening that's impacting learning that's related to anxiety or something else. So having all of those different domains be part of an assessment for someone who's a school age or an adult can put together a pretty detailed picture of where there are strengths and where there are areas of need that then help form the recommendations and interventions that are needed for that person.
Great. Thank you, Dr. Johns. Dr. Urata, another question for you from Jerry. I'm curious about any experience with Cruzon's and hyperactivity, ADHD. We've related it to sleep apnea and not resting well. We've been successful with the CPAP, but still have some concerns. Any thoughts about that?
I probably would defer that question to Dr. Johns. I mean, at first pass, I would say I'm not familiar with any association, but Dr. Johns, do you know of anything?
We did see in some of those studies that there were pretty high rates of ADHD compared to the general population for several of the syndromic synostosis. And so I think that may have a component, and it's probably multifactorial. So certainly very important to address the sleep apnea, but that may not be enough to look at all the underlying causes of ADHD. And so, but I think in essence, you would have a multidisciplinary treatment plan where you're looking at maybe working with the school, with a behaviorist, potentially with psychiatry or a pediatrician for medication management, and definitely keeping on top of the CPAP and other things related to airway that are huge in ADHD as well.
Yeah,
Great, thank you.
I would just echo the part about the multidisciplinary team, because I think having, for example, we have Dr. Ward, who's a sleep medicine and pulmonary specialist. So having all these people in one room talking about these kids, I think is really important.
Yeah, absolutely. Thank you for that. Samantha, can I ask you a question? What are some of the things that you were on the lookout for when Jake was a baby or young child? Like, for example, headaches. Mm-hmm. What did you and the medical team that Dr. Urata and Dr. John just talked about do to address those issues? And as Jake has gotten older, what else have you been on the lookout for?
So headaches has always been a big one for Jake. And when he was a baby, he did have an issue where he would throw up. And so now looking back, I think it was because he's always gotten headaches that were, migraines or, that we went through all the testing just to rule out everything. We did swallow tests. We did CT scans. We did MRIs just to make sure, because he couldn't tell me when he was a baby. Now, as he's older, we're still, he tells me now I have a headache, and we know if it's a bad headache, and one of those headaches, we call them. So we looked for that. We also, I mentioned the breathing before. Jake, when he would get even just a little cold, I would notice that his like I could hear like a little, like a wheeze, and we would pay very close attention to that. And also the ears. So sometimes, we wouldn't know what was wrong, and it wouldn't come, they always say like, oh, well, he doesn't have a fever, then he doesn't have an ear infection. I'd call the doctors and they'd say he doesn't have a fever. But for Jake, his ear infections didn't always have. So sometimes it would take just seeing the drainage. But I would say now, again, looking back, if I could do it differently, I would just insist on having his ears checked, because a lot of that crying and that, came from ear infections that he had. So those, I think, are the kind of the main ones. The breathing. I used to watch him at night while he was sleeping because I was so nervous. And but yeah, those are the things. I wish I could go back, and so I hope someone will learn from those things. But the ears also, because he had so many ear infections, and that was a lot of his pain was coming from those ear infections.
Great. Thank you, Samantha. So I have a question for Jake. When you meet new people, do you typically tell them up front that you have a craniofacial condition, or do you only address it if somebody asks you about it first?
Well, when I was younger in elementary school, we wrote a book about to read to my classes at the beginning of the year. It had pictures of me and pictures of my family and things like that. And pictures. Then kids could ask me questions or not. But now, since I'm older, people don't really ask me, or I just wait to see if they ask me, but they don't really ask me questions.
We did. We wrote. Well, I wrote this like a book. I did it on Shutterfly, and I had pictures, and it was called like All About Jake. And at the beginning of the school year, we would read it to the class, and then let the kids ask questions. But it was actually amazing, and some of the kids would ask questions, and they would say things like, why do your eyes look like that, or why are your fingers short? And we would say, well, this is how Jake was born. But look, there were pictures of him as a baby. There were pictures of him skiing and doing all the things that, the other kids would do. And then there were also pictures of, him having sleep studies or things that, maybe he, had to go through that they didn't have to go through. And so, but as he's older, he doesn't let me do that anymore. Just let me go into his high school and read the book.
Well, that's smart. I like that.
Yeah.
I'm going to ask one more question. Oh, let's see. Dr.
I have the names of those those Facebook groups.
Okay. Do you want to save it there, or you can? Maybe what we can do is, can you save it there?
You want me to put it in the chat?
Yeah, that'd be great. That'd be great. So let's take a question from Russell for Dr. Urata. What do you tell families in regard to how many surgeries a patient may undergo? How do you prepare them for the marathon? Good question. I think we're having trouble hearing you, Dr. Urata.
Oh, so sorry. I was going to say that
Okay.
Dr. Russell Reed is a craniofacial surgeon at the University of Chicago. So I don't know if he's punking me or if he just wants to see, how we do things differently. But he is a remarkable surgeon in his own right. The question is a great question, because I would again go back to my analogy of LA traffic on any given day. And Samantha knows this, and so does Dr. Johns. If you're going from Children's Hospital to LAX, you might take one of 15 different routes. And the same thing is true for when you're taking care of kids with syndromes, because each kid, you might have to take a different turn, because maybe Jake has a little relapse, or maybe his left orbit's a little bit further down than you want it to be, or maybe his teeth are erupting slower. All of those things that I said at the beginning were characteristics that could alter your pathway. Determine how many surgeries you're going to have. So what I have a tendency to do is to talk and show the families now this roadmap that is developed, that I've developed, because the roadmaps are very specific to the surgeons. Because Dr. Reed and I might, as an example, if we listed all the surgeries that we do to take care of these kids, it's likely that our list of surgeries are different. I did box osteotomies for Jake. There aren't a lot of surgeons that are doing that to bring the eyes closer together. I love that operation. It's a complex operation, but there's probably less than 5 people that are doing a lot of those on a yearly basis. So the conversation I have with my patients has more to do with, this is the roadmap, and we don't yet know what the path is going to be, but just understand if we need to take a left on Melrose, 3 years from now, that's a possibility. So hopefully that answers the question, Russell, and I look forward to seeing you.
Thank you, Dr. Urata. this has just been a terrific conversation. I wish we could get to every single question that we have, but we will answer you in email form after the program is over. And if you do have more questions, please write to us at info@myface.org. Just to say that we've just put up the two Facebook groups, APERT International and APERT Syndrome and Syndromic Craniosynostosis Awareness Group. So please take a look at those. I want to give my heartfelt thanks to Dr. Johns, Dr. Urata, Samantha, and Jake. You all are incredible. What a wonderful, wonderful presentation. I think it was incredibly informative, and I thank you so much for your time today. I do want to talk about, before we go, a guide to craniofacial surgeries that MyFace has available that helps patients and families to better prepare for some of the most common craniofacial surgeries. These resources include background information on each surgery, supplemented with expert medical advice and firsthand accounts from patients and families who've gone through these procedures. So please, I encourage you to use this free tool. Go to myface.org/surgeries, and you will find all this information that will really help you. Craniofacial differences impact the body and the spirit so significantly, and MyFace provides direct services such as access to patient and family support groups, topic-driven workshops just like this one, online programs that all serve to educate the community. And as Dr. Urata was talking about, it's education, it's working with a team and finding the team that works best for you to go on the journey that you're going to be going on. And we find that to be the very best way to advocate for yourself. So we make that a really important priority at MyFace. We host unique networking opportunities that really seek to bring our community together because we want to empower the spirit and build strength so everybody can be as strong as Jake. He is amazing. We want families across this country to know that they are not alone. And for more information, we ask you to take a look at our website, myface.org. I'd like to invite you to a couple of upcoming events. First, on Wednesday, February 15th at 12 p.m. Eastern Time, we have the next My Face, My Story episode titled The Power of Facial Difference, a conversation with David Roach, who is an inspirational humorist. He's going to be speaking with Dina Zuckerberg. Please go to myface.org/mystory to register for that program. You can also join us on Monday, May 15th at 6 p.m. Eastern Time for My Face Celebrates. This special evening of hope, resilience, and community will feature musical performances from children and adults, all with craniofacial differences. We'll be presenting some awards, and it will be a celebration of the craniofacial community. You can participate either in person in New York City, and if you're not in New York City, you can join us online. More details will be on our website very soon. And then coming in the summer of 2023, we have our next installment of the Transforming Lives webinar with a program called Navigating Adolescence with a Craniofacial Condition, Strategies for Empowerment and Success, featuring Meredith Albert, PhD, and Canis E. Crarand, PhD. Again, more information will be on the website very shortly. At MyFace, we strive to provide the most helpful and informative resources for those with a craniofacial difference. To help us do so, we ask that you take a few moments to complete our brief survey by visiting myface.org/cranio-webinar, and please let us know what you thought of this webinar. We've also provided information in the reminder we sent, and we will also send you this information in the email you'll receive after the program. Again, I want to thank all of our speakers for being here tonight. I want to thank all of you for sharing your time with us today, and I want to wish you all a wonderful evening. Thank you so much for joining us.